Welcome to the Radiology Vault, an open repository for radiology educational content designed for learners and medical professionals. Presented by the Michigan Medicine Department of Radiology.
I am Ashok Srinivasan from the University of Michigan, and today we are going to be talking about an approach to tinnitus. I don't have any relevant financial disclosures. Well, we're going to talk about first how tinnitus is classified and then zoom in on the role of imaging for tinnitus evaluation. Tinnitus is essentially a sound that's perceived without an external stimulus, and it affects a lot of people at any point of their lives. So the severity can be barely noticeable sometimes, and it just is transient and goes away, or it can be debilitating and require some type of medical intervention. In cases of tinnitus, it is very critical to obtain a detailed history because the presence of associated symptoms like hearing loss, vertigo, or headaches can actually zero in us on the potential pathologies. We also need a comprehensive physical evaluation, otoscopy, as well as audiological testing before any patient is referred for an imaging examination. And tinnitus is simply classified as non-pulsatile versus pulsatile, whether it is coinciding with the heartbeat or not, as well as whether it is subjective or objective. And it is important to note that many more people have non-pulsatile tinnitus than pulsatile tinnitus, and the subjective tinnitus is far more frequent compared to objective tinnitus. And also, you can think about it this way: lots of patients who have non-pulsatile tinnitus might have it only subjective, where they hear it but nobody sitting next to them can hear it. Whereas many patients with pulsatile tinnitus, it can be subjective if it is not very loud, but it can also be subjective and objective, which means the physician sitting next to the patient can actually hear the tinnitus. So for non-pulsatile tinnitus, important to remember that most often this is functional and it occurs after exposure to loud noise, medication toxicity, etc. And they will not have imaging abnormalities. So if imaging is needed, it's usually because they have some associated symptoms like hearing loss. And very important to remember that contrast enhanced MR is usually the study of choice for evaluation of non-pulsatile tinnitus. And the most common condition somebody is looking for is there a tumor like a vestibular schwannoma, which is associated with tinnitus but also with hearing loss. There are a variety of other conditions that are listed here that can also cause tinnitus, but these are usually more rare. So let's focus in on pulsatile tinnitus. That's where the imaging is going to provide the best bang for the buck. Again, workup will often disclose an imaging abnormality. And remember that workup of pulsatile tinnitus can go in different pathways. It can start off with a CT temporal bone followed by a CT angiogram of the head and neck. It can also start off with an MRI brain focused on the cranial nerve 8 along with an MR angiogram brain, or a combination of these cross-sectional techniques. And finally, if you want to troubleshoot, you might have to go to a conventional catheter angiogram as well. There are three broad categories of diseases that we should think about when we deal with pulsatile tinnitus. The first one is vascular tumor. So the most common tumors that cause pulsatile tinnitus are going to be associated close to the skull base. So remember it as paragangliomas like sitting in the jugular foramen like glomus jugulare, or going into the middle ear cavity like glomus tympanicum, or a combination which is the glomus jugulotympanicum. And this is an example of a jugular foramen paraganglioma demonstrating flow voids on T2 weighted images, intense post-contrast enhancement associated with some degree of slow flow within the right transverse and sigmoid sinuses. And this has the classical salt and pepper appearance. This is another example of a paraganglioma in the jugular foramen. This is on the opposite side. Again, the presence of salt and pepper, pepper being the flow voids on T2, salt being the bright specks that we see on pre-contrast T1 weighted images, is quite indicative of this diagnosis. If you want to correlate with CT, you can, and this is showing the permeative appearance of the bone. So this is quite classic for paragangliomas. The second category of lesions that can cause pulsatile tinnitus, you have to think about vascular malformation. It comes in two flavors: whether there is a communication between the artery and vein that is abnormal but also involves a nidus or not. If it has a nidus in between, you call it an arteriovenous malformation. This is an example of a nidus in the right carotid sheath. This is asymmetrically enlarged on cross-sectional images. And when we do a conventional catheter angiogram, so this is injection into the right carotid artery, you can see the carotid is filled in, but there's also like a nidus filling in, and there is filling in of the jugular vein that's coming down. So this is shunting into the jugular vein. So this is an arteriovenous malformation. In many instances, you will actually see an arteriovenous fistula as the cause of pulsatile tinnitus, and this is one such example. This is an MR angiogram demonstrating the presence of abnormal signal within the transverse sigmoid sinuses as well as the jugular bulb, which normally will not show signal on a time of flight MR angiogram. And this essentially means there have been protons from the arterial side that have escaped into the venous side and therefore are demonstrating signal. And this is an indirect sign. If you see this, you will often have to refer the patient for a conventional catheter angiogram. And that was done in this case. These are external carotid injections that demonstrate the presence of multiple feeders into a fistula that is dumping into the transverse and sigmoid sinuses. And you can see this is the jugular vein. So the supply here was from middle meningeal as well as occipital arteries. Another example of a vascular malformation, this is much more complex. You can see the shunting on the MR angiogram neck. And so a conventional catheter angiogram was performed. This showed there was blood flow from bilateral external carotid arteries. So the bottom line is, for pulsatile tinnitus patients, carefully look for vascular malformations, either a fistula or an AVM. The third category is vascular anomalies. So it is unclear sometimes why vascular anomaly would cause pulsatile tinnitus, because these have been usually present for a long period of time or are congenital. So when you see this, please remember to search for other treatable causes before deciding that this can be the cause of pulsatile tinnitus, because this could be just incidental. Here is one such example. This is a high riding jugular bulb where the bulb extends above the level of the floor of the internal auditory canal or tympanic annulus. So this by itself is usually not a cause of pulsatile tinnitus, but when this starts eroding the bone and causing dehiscence, the pulsation of the jugular bulb can be transmitted to the middle ear cavity. And in some instances, it can also develop a morphological abnormality like a diverticulum, and that is often associated with pulsatile tinnitus. Here is another example that I think we should all start recognizing. This is the region of the left sigmoid sinus. So the left sigmoid sinus, as it curves, should always have a nice bony covering on its anterior and lateral aspects. And whereas you don't see that bone here. So there is actually dehiscence of the sigmoid sinus plate. So this was a patient with whooshing sound in the left ear, and the cause of this is the sigmoid plate dehiscence. And this is an under-recognized entity because we don't really know this exists. If you don't know really if this exists, you may not be able to pick it up. This is important to recognize because if you recognize this, these have a much higher incidence of cure after surgery because they will go in and put in a graft to prevent the pulsations from being transmitted. This is another example of a sigmoid plate dehiscence. This is on the right side. And this time there is a morphological abnormality of a diverticulum as well. And this was the cause of pulsatile tinnitus. Aberrant carotid arteries have been associated with pulsatile tinnitus. This is actually a really interesting congenital abnormality where the cervical segment of the internal carotid never develops. So in fact, the brain, trying to get its blood supply, pulls up the external carotid branch, which is called the inferior tympanic artery, which supplies the caroticotympanic artery and forms this anastomosis. So the brain has found a bypass pathway. Now the interesting part about this is this bypass pathway takes it much closer into the middle ear cavity, and therefore when it reaches into the middle ear cavity and sits over the cochlear promontory, there is a chance that the pulsations can be transmitted to the middle ear cavity. So this is one such example of an internal carotid artery being nicely draped over the cochlear promontory. But these patients are essentially born with this, so it's not clear whether this would be automatically the cause of pulsatile tinnitus or not. Here is another example of an aberrant carotid artery which is suspected on the non-contrast CT in a patient who is just 5 years old, and when we give contrast, it's very clear that this is indeed the internal carotid artery where this is sitting right over the cochlear promontory. There are also miscellaneous causes of tinnitus possible, such as transverse sinus stenosis, sometimes enlarged emissary veins, and even patients with carotid stenosis or otosclerosis or Paget's disease, because it is a hypervascular condition, can cause tinnitus. But those are always diseases of exclusion. So in summary, most patients with tinnitus will actually not show imaging abnormalities. It is important for you to know whether the patient has non-pulsatile tinnitus or not, because if it is non-pulsatile, you usually will start off with an MRI brain and look for a CP angle abnormality. If it is pulsatile tinnitus, you use a combination of temporal bone CT, CT angiogram, MR brain, and catheter angiography. And always try and follow a three-pronged approach to patients with pulsatile tinnitus. Is it a vascular tumor? Is it a vascular malformation? or are there vascular anomalies? With that, I thank you for your attention.